My name is Dr. Jon Hernandez. I work here at Lehigh Valley Orthopedic Institute at Lehigh Valley. I've been here for a while. I've been in the Valley for a while. I've worked at Coordinated Health in St. Luke's and now most recently here. And currently I have offices in the Hazleton area, the Lehighton area, and also now in Allentown. So I'm just going to talk about a couple of issues, most common issues of the hand and upper extremity. So I'm sure at the end you'll have some questions about any specifics that you have. I know we mentioned kind box earlier, so if there's any questions you have regarding any other topic that we haven't covered, that's fine as well. So we'll go ahead and get started. I have no disclosures for this talk. So here are the things I'm going to talk about. Carpal tunnel syndrome, that's the #1 condition that we as hand surgeons see. That's what I'll spend most of my time on. Then we'll talk about some tendinitises, such as de Quervain's disease and trigger finger. And then we'll talk about arthritis, being the thumb being the most common, fingers, and also the wrist, okay? So carpal tunnel, we'll talk about what it is, pertinent anatomy, diagnostics, and treatment options. So carpal tunnel syndrome is the #1 neuropathy of the upper extremity, and it's a neuropathy of the median nerve. And the median nerve is shown just to the right there. It's a nerve that innervates the thumb, the index, the long finger, and then the half of the finger that's closest to the thumb. So you'll see that's colored in blue. And so people who have carpal tunnel syndrome will have numbness and pain that's in that same distribution. Patients will also complain of night symptoms, where they wake up in the middle of the night with pain in that distribution, having to shake out their hands. During the day, they typically talk about dropping things. When they pick things up, they don't have a sense of awareness that they have something or how hard they're grasping onto it, so they end up dropping things. So that's a pretty common complaint. So who gets it? There's about 1 to 3 new patients per 1,000 individuals per year. The overall frequency is about 50 out of 1,000 persons, and so that's about 1 in 20. So maybe one of you in this room here has it. Female ratio is about 3 to 1. Commonly occurs peak at around 40 to 60, but there can occur anywhere in between that, and it can occur earlier than that and certainly later than that. A little over half of them are bilateral, meaning both hands, and 10 to 20% occurs in the workers' comp, which does put a great deal of financial burden to the worker for work. Carpal tunnel release is the #1 hand surgery procedure that us hand surgeons perform. So just some pertinent anatomy. So there's a band here that comes across the wrist just underneath the skin. It's called the transverse carpal ligament. So the carpal tunnel is truly a tunnel in which the structures from the forearm pass through that tunnel to make their way into the hand. And in cross-section view here on the right, that tunnel is formed by a row of bones that make a C, or inverted C in this case. And then the ligament, I'll show it here in red, forms the remaining part of that tunnel. And through that tunnel, the structures that run through it are the tendons that are kind of in this pinkish and gray coating here, and then also the nerve, the median nerve, again, that innervates half of the ring, the long finger, the index finger, and the thumb. So here's a nerve in sort of a cross-section. I liken a nerve to similar to a cable. So it has an outer coating to it, or a insulation part to it, and that's sort of what we see in a nerve as well. You have this insulation or epineurium. Then you have a bunch of little cables or wires that are inside of this cable itself, and those are the neurons, or in this case the axons. We call them neuronal axons. And if you kink this nerve, it can suffocate the nerve from its blood flow, just like a garden hose. If you were to bend the hose, you'd stop the flow out of it. You unbend it, flow starts. And that's fairly simple for, and that's how you can get the symptoms, and that's how you can certainly relieve the symptoms. And we typically talk about bending the wrist, putting it in a flex position. That can kink the nerve, cause decreased blood flow. You open it back up, the blood flow returns. If that happens over a long period of time, just like a hose, if you keep it kinked for a long period of time, you can get cracks in it. You can get some long-term problems with that where you start to get leaking out of the hose. Well, the same thing happens with the nerve. You get long-term loss of blood flow. You can have sequentially loss, more significant loss of function of that nerve. Something would be something that's immediately recoverable, can be something that's very slow to recover, or something that would have permanent changes, just like you would have in a garden hose. So what causes carpal tunnel? What's the etiology? There's two components to this. There's either the tunnel's too small or the contents, there's too much within that tunnel, and that causes pressure and puts pressure on that nerve, and that's what decreases the blood flow to the nerve. So there's anatomic variation. Everybody has different size hands, different size wrists. There's wrist position. We talked about wrist flexion. Typically when we sleep at night, a lot of people sleep with the wrist bent, and that you wake up and it's numb. And you reposition your wrist, that numbness goes away. There's also post-traumatic changes or arthritic changes. So if you've had trauma, you've broken your wrist in the past, you can cause narrowing of that tunnel. If you have arthritis in the wrist bones, that can also cause narrowing changes of that tunnel. If the contents of that carpal tunnel are too full, too heavy, too thick, you can get compression of the nerve just as well. We typically think of the most common as being fluid, and this can happen in pregnancy, it can happen in inflammatory disorders such as rheumatoid arthritis, and also with activity. Just like when you go lift weights in the gym, your muscles will start to swell. When you start to do activity, the synovium, which covers those tendons that we talked about, they can start to swell up as you pump more blood and more fluid into the canal. Some of these other things, such as extra and large lumbricals, those are muscles that attach to the tendons that you saw on the previous slide, or extra or large tendons. That's pretty rare, and even more rare is space-occupying tumors, such as ganglion cysts. We mentioned that earlier in pre-talk. Lipoma, fibroma, those types of things can cause increased pressure in the canal. Other etiologies include smoking, diabetes, peripheral vascular disease, hypothyroidism. We talked a little bit about inflammatory arthropathies such as rheumatoid arthritis, and in some cases just idiopathic, we just don't know. Aggravating factors, task-related factors such as repetitive activities where a lot of force, a lot of repetition, that can cause increased fluid that we talked about earlier. Posture or position of the wrist can also change and cause either increased fluid or decreased or increased compression on the nerve as it kinks around that band. Power tools, probably one of the most, we typically say that most activities don't cause carpal tunnel syndrome, but they can aggravate. Power tools are probably cause enough vibration that we can say that some of those cases, they're a cause of carpal tunnel. Temperature changes, cold slows down the blood flow, therefore decreases the fuel to the nerve, and same thing with heat. If it's heat, you get more blood flow, better nerve function. Aggravating factors that are the most common cause of carpal tunnel or are closely related to carpal tunnel is anatomy, age, and genetics. So if you have a child that basically says he can't do his homework because he has carpal tunnel, you can probably tell him that that's probably not the case. So I'm going to go back to this diagram on anatomy. Again, we talked about the bones creating this inverse C, and we also talked about the ligament, transverse carpal ligament here in red. Our bodies, our tissues in our bodies are such that they're elastic. They have an expansile quality, but they also can contract as well. When we're asleep at night or we're cold, those tissues contract. When we're up in the day and we're active and it's warm, those tissues open up or expand. And you can see if that red band there, that transverse carpal ligament, in the morning when you wake up, you're cold and you're inactive, that's likely tightened or shortened, and that will pull on that bone, that inverted C of the bony congruence there, and that will close the canal. When you're up and awake, it will open it. And so when you're awake and you're active and you're doing things, and I mentioned earlier that you can cause fluid going into that carpal canal and causing swelling of the canal, or swelling of the tissues inside, well, that's when that tissue expands and it allows for that to breathe. It allows it to, it compensates for that increased fluid within the canal itself. So that's the dynamics of the carpal tunnel. We typically diagnose this with a clinical history and physical exam. Things that we ask the patient are, does this change with your modification and activity? Does your carpal tunnel symptoms go away with wrist splinting when you wear them at night? Do you respond to steroids? Do those help? And we also don't necessarily diagnose carpal tunnel with electrodiagnostic testing. And for anybody who's had one, it's basically just a series of tests where they put little needles in your arm and they send a current through that to test the function of the nerve. We typically don't use that to diagnose, but we use it to evaluate the severity of the disease process, which I'll talk about in a moment. So during evaluation, we want to know, does the numbness and tingling that you perceive, does it fit with the anatomy of the nerve? Do you have the numbness in the thumb, the index, the long finger, and that half of the ring finger? If you do, then you likely have carpal tunnel syndrome, or at least something that's affecting the median nerve. We do provocative testing of the carpal tunnel to test to see if that is in fact the case. So we do, Phelan's test is where we hold your wrist in a flexed position. We'll hold that there for a period of time. And if you start to notice numbness and tingling, you likely have carpal tunnel syndrome, or at least that's a positive test towards that. Median nerve compression, that's where we press along that ligament, that band that runs across there, we press on the top of it and we put pressure on the canal directly. If you start to feel numbness and tingling, that's also a sign. The hand diagram we talked a little bit about the electrodiagnostics, and then we also ask about the response to non-op management, which we just discussed, the splinting, the steroid response, and change in position of your wrist or change in activity. We rarely use any imaging studies to diagnose carpal tunnel, like x-rays, ultrasound, or MRI, so you probably won't ever see us order those for that. So you have a high likelihood of carpal tunnel syndrome if you have a diagram, your numbness fits that median nerve diagram in those 3 fingers and half of the ring. If you have decreased light touch, if you have median nerve compression test, which is pressing on that canal, and if you have nighttime symptoms where it wakes you from sleep. You have a 90% probability that you have carpal tunnel syndrome if you meet those criteria. If you don't have any of those, you're probably less than 1% chance that you have carpal tunnel syndrome. So electrical studies, I wanted to just kind of mention this because I did state that we don't use this necessarily to diagnose, but we use it to categorize the severity. So we typically, after getting an electrodiagnostic study, we rate these as either mild, moderate, or severe. If they're mild, you typically have a chance of full recovery with non-operative treatment. Injection, splinting, therapy, those types of things can help with that, and it can likely go away with those types of a non-operative treatment. If it's moderate, likely to have full recovery with operative treatment. If it's severe, we can take care of the nighttime symptoms, the symptoms that wake you up from sleep at night, but some of the numbness may be permanent. You have the poorest chance of recovery even with a carpal tunnel release with operative treatment. So how do we treat this non-surgically? We talked a little bit about some of these things. We can address the comorbidities such as the diabetes, the hypothyroidism, so that's all managed a lot by your medical doctor. Things that we can do as orthopedists, hand surgeons, nocturnal splinting your wrist at night, keeping it straight so that when you're sleeping you don't bend that wrist and cause chronic compression of that nerve. You can do modification in your activities, steroid injections, and we briefly talked about hand therapy, which they can do some stretching and strengthening exercises. So when non-operative treatment fails, we typically go and consider carpal tunnel release. We can either do that open as an incision, or we can do it through a small, we call it closed, but it's still through a small incision, but it's a small incision in the wrist. And I'll demonstrate that to you in a minute. So that's where we widen the carpal tunnel, okay? Rarely do we need to debulk the carpal tunnel. So we typically talk about taking that ligament, cutting it so it widens. And that's typically what we see. When we go in there and we cut it, you can see the band separate, and it takes the pressure off of that nerve, and you can almost see that relief. And when that happens, your nerve is starving for its blood supply. So it's vessels around the nerve and inside the nerve, they dilate. And so when you release it, all of a sudden there's a big flush of blood going through there, and you can see it kind of just this red occur through the nerve. And this is one of those cases. So this is an open carpal tunnel release. So this is an incision placed in the palm, and we cut the transverse carpal ligament, as you can see here by this dotted line. Once we cut that, the band separates, and it's kind of hidden underneath the skin here. But what you see underneath is this dark purple. It looks purple here, but it's sort of this red flush, this revascularization of that nerve. Endoscopic carpal release is performed. We're doing the same thing. We're still cutting that band, but we're doing it through a small incision in the wrist. What's the difference between the two? The incision in the hand is this glabrous skin. The non-glabrous skin is outside of the palm. So when you make an incision in here, the healing is a lot more tender in the area of the palm. So we've gone to these endoscopic treatments where we make the incision outside of the palm, and we do this through a camera. And so we make this small incision right here in the wrist, and this is the device that I use. It sort of kind of clips the ligament, if you will. It's almost like a clothespin. So it isolates that ligament so you don't see anything else, and you know you're only cutting that ligament. And this is sort of a cross-section of that, looking at it longitudinally. This is the ligament running here, the transverse carpal ligament, and this is the device with one limb going above, one limb going below. And there's a scope that we put inside of those limbs, and this is kind of what it looks like, looking from the carpal tunnel or looking from within the tunnel and looking upward. This is looking in the above limb looking down. So you can see that transverse carpal ligament, the ligament that we want to cut, it's isolated. And this is what it looks like when it's cut. So when you cut it, you can see the two ends of the band, one on this side and one over here, and it separates. It separates. There's usually a fair amount of separation that you can see, and you can almost hear the nerve being relieved after you create that increased volume for the nerve. So treatment results, non-surgical. Typically, the best results are with early or mild symptoms, or early onset or initial onset of cases. For other moderate and severe, it buys you some time, defers you until you need the carpal tunnel release. So the goal of the non-operative treatment is to just kind of get you through, get you to sleep at night. And if it continues to be a problem and the non-operative treatment no longer works, then we can talk about surgery. And surgery has a 90% success rate, so it's very good at relieving the symptoms. There are complications with both non-surgical and surgical treatments. The biggest complication from surgical is an incomplete release. And usually this occurs more common in those who don't do a whole lot of carpal tunnel releases. And there is a recurrence rate at 5 years of about 40%. Usually the earlier you get it, the younger you get it, the more likely you are to have that recurrence at 5 years. So just take home points. Conservative treatment is recommended prior to referral for any mild or acute cases. And that includes, again, splinting, activity modification, hand therapy, and steroid injections. Surgical treatment for mild cases that don't respond to non-operative treatment, or any moderate or severe cases. And avoid being referred late, as there is more morbidity with that. The surgical treatment is very similar to carpal tunnel. We make an incision over that area, and we just make a cut through that band, and again widen the opening to allow for the passage of those tendons. Trigger finger is another type of tendon entrapment. In this case, it's in the fingers. This little pulley system here in the finger is seen on the side, image on the right. That's where the tendon gets hung up. It gets tight, and it can cause the finger to kind of snap closed, snap open. And that can be painful a lot of times, and it can also be functionally a significant problem when you're trying to let go of something and your finger's stuck down. So again, similar treatments. We can do injections, therapy, and eventually we can do surgery where we cut the band so we can allow the tendon to pass through without any problem. Now to go on to talk about arthritis, there's different types of arthritis. Osteoarthritis is the wear and tear arthritis. That's you know, the older we get, we're going to get arthritis. We're going to wear out the tires on our car. Inflammatory arthritis, like rheumatoid arthritis, that's something that is genetic. And then there's, of course, trauma. If you had any injury, fractures to the bones or joints, you're more likely to get arthritis. So symptoms include achy pains in the joints, swelling, changes surrounding the joints. You get cysts, you can get grinding or a crunchiness as you move your joints around, whether it's the fingers, the wrist, or the forearm, or any other joint for that matter. Treatment includes medications, splinting, injections, therapy, just like anything else, and surgery, which can include replacements, joint replacements, joint removal or reconstruction, and then joint fusion, which is an arthrodesis, which is basically getting rid of the joint and making where the joint space was, we make it a longer bone with no motion through that joint. Most common, or one of the most common arthritides that we see and treat are thumb CMC arthritis. That's at the base of the thumb. So we typically call this horseshoe pain, pain around the area in a U shape around the thumb. That's very common, and on the slide to the left you see that red arrow, that's pointing to the joint. If you look at the remaining joints around the wrist, they're open, they're smooth, but at the thumb where the arrow is pointing, it's sclerotic, it's very white, and that's a loss of cartilage, and then the bone is starting to build up. You have increased calcium, so that's why it's more whiter at that arthritic spot. We can inject this joint, we can do hand therapy, and we can also brace the joint, but we don't want to, again, immobilize the joint. We just want to add support. So a supportive brace without any stay or material that's going to create immobilization. And then last, surgery. So we take out that arthritic joint. What we do is we just get rid of the small bone of the joint so that there's a space in between. And you can see this better on this diagram here. There's a space in between. How do we keep that bone from sliding down in that space? We usually do some sort of treatment where we put in an anchor or we do a ligament reconstruction to hold that thumb bone up out of that space. Arthritis of the fingers, again, treat these non-operatively or operatively. If we're going to treat them operatively, this is a fusion, this is an arthrodesis. So that's where we take the joint, we remove it, and we put some type of fixation across there to allow that joint to fuse and become just one longer bone at that point. So there's no more motion at that joint. Usually when you're at this point, you've probably lost a lot of motion in the joint already. And then we have joint replacement. You can see that in this joint here, where we have implants that we put in, and these now act as the new joint surfaces. Wrist arthritis. Normally the ligament between this is the lunate bone here, this is the scaphoid. Over time, the ligament between these two bones loosens or relaxes, or it becomes stretched out, if you will. The bone above it, which is the capitate, that kind of drives in between, and then you kind of see this picture where it you see this kind of pile driving in between, separating the two bones and causing arthritis, particularly of the scaphoid bone and the radius. So we can treat this in several different ways. We can either get rid of this bone, and this bone, or what we call the proximal row, which is, you can kind of see it here, it's this little smile of bones, and we let this bone articulate with the radius bone, or this part of the joint. And we can see that here. That's what this picture is. We've gotten rid of those bones, and this is the new joint. You can see the space in between the two bones, and that's the good cartilage up against good cartilage, and that restores the joint motion. You lose a degree of motion, and I don't mean 1 degree of motion, like but an arc of motion. So you usually lose about 50% of the motion. But again, by that time, you've already lost that motion. Or we can fuse this bone. We can put this bone back into position so it's more lined up anatomically like you see on the left, and then we can fuse those together, and here we use staples. There's a partial joint replacement, or there's a full joint replacement where we have 2 metal trays with plastic spacer in between. So that's it for the talk. I want to thank Lehigh Valley for allowing me to give this talk, and I want to thank you guys for coming and listening.